most of the patients will be more towards the aesthetic side nowadays, okay, rather than convenient side. So aesthetics as point of view, and they boast a lot of things about aligners. It's more aesthetic, more invisible, more advantages. I will explain what is the difference between this fixed appliance and aligners and what goes on and they have effectively. But I just want to explain the conventional ceramic and lingual and self-healing differences between these common appliances. Okay, but the conventional appliance, as you all know, is nowadays we have MBT prescriptions. Previously it was a lot prescription, now it is going to be MBT prescription only. So here you have a module, you have to tie the wire with a bracket. And in conventional, you have ceramic brackets, you have naturally what you call as two colored wires are also available which are polymer coated, but there is not that much versatility nowadays. But if you want a really invisible orthodontic, it's going to be the lingual orthodontic. Okay, the only drawback, simple drawback is this little bit of inconvenience for the patient to while having a speech and everything. This is a common effect whenever you have a prosthesis. The same issues do happen in the early stages. That is what happens with lingual appliance also. But it's a very big work for the practitioner to have a lingual appliance, and if there is common debonding, everything is going to be helpful for the orthodontist. Okay, but still lingual braces are practiced now and then everywhere. But the real invisible is going to be the lingual braces. Of course, there is a lot of hype now for self-ligating braces. The Demystified system, which says that whenever you do a self-ligating brace, it expands automatically, it aligns everything, only for extraction, everything. But there is no sufficient evidence to prove all these things. But still, there is some advantages of using a self-ligating bracket. One is having less friction, definitely. So there is no less charge that you can spend. By putting modules, you will spend a lot of time there. So just locking the brackets, you can have a wire, tying the wire, change the wire is going to be very easy. And definitely there is a very less friction, so the time consumed to move a tooth from one place to another is going to be drastically reduced whenever you use self-ligating bracket. Definitely there is an advantage, but whatever the Demystified system boasts, I don't think there is sufficient evidence that says it solves every problem. Of course, it has some advantage. Self-ligating does have an advantage. So the plaque control also will be a little bit efficient whenever you can brush properly. So you can clear the plaque easily. And of course, aligners is going to be the future of the orthodontics. And then definitely there will be a cycle again. Okay, whenever I say aligners, this is what in every net, you can see they download this from net actually. They say clear is invisible. Is it invisible? Is it invisible? How? Okay, but lingual braces, you can't see the end of the outside. Definitely, not invisible. Still, you have some attachments over the teeth. Okay, whatever attachments you do in the fixed appliance, you do some attachments in the composite, with the braces also, with the clear aligners also. And what are all they are used in fixed appliances like e-chains, class 2 elastics, tags, everything now they use in nowadays using the clear aligners. So they are almost using every aspect from the fixed appliances nowadays to the clear aligners and saying that clear aligners are there. So it is just a business hype anyway, but I don't want to go into detail about that business aspect. And this is a removal appliance. Still, you have all the way you have that is the disadvantage of having a removal appliance. It depends only on the patient's convenience. Whenever the patient doesn't wear it, it's not going to work at all. And there's no effect on oral hygiene. There is no evidence saying that there is no effect on oral hygiene. Definitely, whenever it is in contact with the teeth very closely, whenever it could get impacted or the patient is not brushing properly, the designer is going to place that foot very close to the teeth. Definitely, there is a loss of mineralization. Everything will happen, and they cannot say there is no effect on oral hygiene. And no change in heating habits. Of course, this may help. Very comfortable and convenient. I don't think so. Not that much comfortable and convenient. Okay, so patient has to wear it, take it out, put it again. He has to change. Okay, so routinely they have to do something with they have to meddle with it. Instead of doing orthodontist doing all the work, the patient is doing the work, giving extra money to the orthodontist or whoever the general practitioner. He's the highest beneficiary who is going going to get this. And there's a minimal appointment, I don't think so. They have to be followed up. The aligners patients have to be followed up regularly. So tracking, what we call as tracking, is must for the aligner patients. These people come regularly once in a month, or FA patients come regularly, but these people may or may not come. They will be having aligners of their own. And suddenly one day they will land up and show that this is we have to track it again. We have to go for the 10th aligner, 12th aligner, and have to start again from the scratch. So very few visits required. Results can be visualized even before the treatment starts. This can be visualization of treatment can be done with the software. You can do for any case, not only for the clear aligner cases. Visualization of change of the pattern, everything you can see in the software. When you put the software, all the stages can be done in fixed up lenses. So I'm not against clear aligners, but what they boast, they are saying that fixed is zero is unacceptable. Yes, definitely we have to align, we have to select proper cases for aligners. There is plenty of cases you can manage easily with aligners.
I tell patients to go for aligners. அதெல்லாம் சொல்லும்போது நார்மலி they go for ஒரு ஃபேமிலியில் ஒருத்தருக்கு ஆர்த்தோ போட்டிருக்காங்க ஃபிக்ஸ்ட் பிளேஸ் போட்டுருக்காங்க அந்த ஃபேமிலியில் இருக்க இன்னொருத்தர் வந்து அவரே அலைனர் ரெக்கமெண்ட் பண்ணுறாரு அவங்க ஃபேமிலியில் இருக்க போட்டுருக்காங்க ஆனால் அலைனர் போட்டோம் அப்படின்னா அந்த ஒரு கம்ஃபர்ட் பட் அந்த சியூவி பற்றி என்ன சார் அலைனர்ஸில் அந்த
சியூவி இஸ் வெரி இம்பார்ட்டன்ட். யூ ஹேவ் டு ஸ்டிமுலேட் த டீத் ஆன் அண்ட் ஆஃப் டு ஹேவ் திஸ் மூவ்மெண்ட். Periodontal stimulation is necessary. So chewy is a must. So other patient where they have to chew. Otherwise the aligners won't work properly.
Self-alignment ஒரு செக் பண்ணுங்க சார். அதுக்கு ஒரு இன்ஸ்ட்ருமென்ட் வச்சு தான் ஓபன் பண்ணனும் அப்படினு சொன்னாங்க. மாடியூல்ஸ் மாத்த வேண்டிய அவசியம் இல்லை. ஒரு தடவை இத நம்ம மாடியூல் மாத்தறதே அதுல எக்ஸ்பான்ஷன் கொஞ்சம் ஜாஸ்தி நடக்கும்.
Definitely there is an expansion. The payment system says that emphasize expansion. They have their own set of wires. They recommend a set of wires. Along with the bracket, they also supply the wires also. We have to go for that sequence only.
அது பழக்கிறது மாதிரி கஷ்டமா சார். அது
simple, it is very simple. There is one small sharp thing will be there. You have to insert instrument will be there. Just you have to insert inside the slot and just rotate clockwise. This go like that. Bracket.
அது தனியா அது வாங்கணும்னு சொன்னாங்க உண்மையா சார்.
Usually they are supplying along with the braces itself. Okay, whenever you buy braces, self-legging braces, they supply along with it. Please, please.
Straight bro.
Solid.
Solid bro தான் பண்ணிட்டு இருக்கேன். சார் தான் சொன்னாரு. அதுக்கு ஒரு ரிவிஷன் பேர் சொன்னாரு. எனக்கு தெரியாது.
Simple தான். Very easy to open.
What we are using is what chisel variety.
Another chisel now is
Small chisel can slightly do some
thinning.
the walls are straight பண்ணணும் இல்லையா end of
இந்த பாக்கெட் ஆஃப் திங்ஸ் தான் சார் ஜெனரல் டென்டிஸ்ட் கேக்கு ஹெல்ப்ஃபுல்லா இருக்கு. என்ன டென்டிஸ்ட் வந்து எங்க காசு போயிட்டு திரும்ப நம்ம பார்த்துட்டே இருப்பாங்க. ஸோ இட் ஹெல்ப்ஸ். இப்போ கமிங் டு த நெக்ஸ்ட் ப்ரொசீஜர் ஆக்சுவலா இப்போ வந்து பேஷண்ட் நான் பார்த்துட்டே இருக்கிறேன். டூரிங் த கோர்ஸ் ஆஃப் த ட்ரீட்மெண்ட் நான் என்ன பண்ணணும்? பேஷண்ட் வந்து வயர் உடஞ்சிச்சுன்னு வர்றாங்க, வலிக்குதுன்னு வர்றாங்க, அழுது மாட்டிக்கிறதுன்னு வர்றாங்க, சில நேரம் பின்னாடி குத்துதுன்னு வர்றாங்க. இதெல்லாம் வரும்போது இதெல்லாம் நான் எப்படி அட்ரஸ் பண்ணணும்? அதே மாதிரி இந்த நெக்ஸ்ட் டைம் வந்து சில டைம் ஆத்தோட பார்க்கறதுக்கு இது வந்து ஒரு ஸ்கேலிங் பண்ணுங்க அப்போ சொல்கிறாங்க ஸ்டார்ட் சைடில். அது இல்லாமல் நான் முன்னாடியே என்னெல்லாம் பண்ணி வச்சு எப்படி நான் பேஷண்ட்டை ரெடியாக உங்களுக்கு நெக்ஸ்ட் விசிட்டில் ஆத்தோ ப்ரொசீட் பண்ணுறது நான் என்ன பண்ணணும்?
address the loose brackets and more excellent brackets. Whenever you have loose brackets because of some debonding, the patient may not follow your instructions. Usually you advise soft diet, don't have sticky diet, chocolate banana, butter banana, everything you say, but still the patient will take this as an inspiration and again they will start testing whether whatever you told is right or not. Okay, they will testing everything. So finally they will land up in broken brackets. Okay, so don't first tell them don't panic. Whatever you can do is ask the patient to come to you and see whether this bracket is intact or moving this side and that side. So if at all it is moving, if it is a module, you just open it you can take the bracket out. If it is as a self-legging bracket, hold it perfectly, open the lock, remove it, and just make the patient comfortable that it is not a big thing. Okay, so what you can do is you can still bond those brackets another organism, or if you know bonding, still you can do it. The other main problem is going to be the wire is getting extended between distal to the molar. Always you can have some distal end cutters, but don't cut the wire, it's already good wire. Okay, so most of the clinicians will do nice wire, they will just extend, they will cut. So you have to place the wire again to a perfect, then if it is extended, you can cut. Whenever you have some E-chain, whenever E-chain is added regularly, whatever happens, the arch becomes smaller and smaller. So the arch ways get extended back. So that is why the wire is going to extend. You should explain to the patient this will happen if the patient doesn't come for 1 or 2 months. Okay, so they will say initially it was not breaking, now it is breaking like hell. So this happens when, because whenever you are closing the spaces, what happens, there is an arch constriction there. There is a small, what do you call as, shortening of the arch takes place. Okay, the wire is going to remain the same. So this is going to extend beyond the molar. So you have to cut that using a distal end cutter. Always have a distal end cutter with you. So emergency you can manage. Otherwise you will be calling on 10 o'clock or even the you will be calling and making you panic. Okay. And flower control is going to, you have to repeatedly stress the patient that flower control is going to be the prime thing the patient has to do in their part. The brushing is going to be there. Time to inspection, time to time instructions to avoid food that could damage the appliances. You can recommend fluoride rinses, toothpaste containing fluoride, and you can go for fluoride application also for small children and time to time test with them. Any other doubt on the chapter? Of course, government takes care. You can have some gum stimulation, you can do some water flossing. Gum massage is very essential. This should be insisted to the patient. Why? Because usually whenever the gum is not touched, because the brush is not going to have effective contact with the gum also. So we have some inflammation in the edema. So you can see some hypertrophical changes, a lot of hypertrophical changes in extraplanar cases. This is due to there is no gum stimulation at all. So you have to apply some gum stimulation using the gum stimulator, and water flossing is a must. You can't reach the brush everywhere, so water flossing is going to be effective. Some patients are not effective in toothbrushing, so you can recommend an electric toothbrushes. So all these gadgets will help them to keep very clean and make your life very easy.
So அந்த மாதிரி நீங்க வயர் போடும்போதே பின்னாடி குத்துனா வந்து
Cut பண்ணிட்டு சொல்லிடுவோம். You prepare the patient's mind so that they will be unexpectedly they won't have a surprise.
So புதுசா நம்ம வந்து அது கனெக்ட் பண்ணி வச்சிருக்கோம். மார்க் பண்ணும்போது தான் மார்க் பண்ணணும். ரைட். இதுதான் நார்மலா ரெண்டு காமனா வர ப்ராப்ளம். வாட்ஸ் ஆஃப் பேஷண்ட்ஸ் நோ ரீடைனஸ். எவ்வளவு நாள் இது போட வேண்டியிருக்கும். இது வந்து எப்ப பார்த்தாலும் பேஷண்ட் முதல்ல கேட்கறது அதை நம்ம நீங்க முதல்ல ஒரு டிப்பா ஆடா ஒன்று சொல்லுங்க. முதல்லயே ரீடைனர் காஸ்ட் சேவிங்னா சேவ் பண்ணிக்கலாம். அதையும் சொல்லுங்க ஒரு டிப்பா. இன்னொன்று வந்து ரிஸ்க் ஆஃப் நான் கம்ப்ளைன்ஸ் என்ன இருக்குன்றது எப்படி நான் எக்ஸ்பிளைன் பண்ணுறது, ரிலாப்ஸை பற்றி எப்படி அவங்களுக்கு கிளியராக நான் கம்யூனிகேட் பண்ணி அது நான் நார்மலாக வந்து அப்புறம் தான் சொல்லுவேன் சார் ரீடைனர் காஸ்ட். ஏன்னா சில நேரம் 2 வருஷம் 3 வருஷம் ரீடைனர் காஸ்ட் ஏறி இப்போ லேட்டஸ்ட் ரேட்டர் சொல்ல
அது ஒரு மிஸ்ஃபயர் ஆகலாம். இப்போ சொன்னீங்க டாக்டர் முதல்ல நீங்கள் சொல்லலையே சொல்லுவாங்க. அதுவும் இருக்குது. யூ சே த ரீடைனர் பட் காஸ்ட் அப்புறம் சொல்லணும். So you prepare the patient that retainer should be there, but the cost may fluctuate later. So I will tell you, பரஞ்ச கூட பரவாயில்லை குறையுங்க, நான் அப்போ சொல்றேன்.
இந்த மாதிரி கம்மியாக சொல்லுவேன்.
நடக்காது சொல்லுறது நடந்துருக்கேன்.
தெரியாதவங்களுக்கு சொல்ல தெரிஞ்சதுக்கே சொல்லுங்க.
சரி, 5 வருஷம் முன்னாடி சொன்னதெல்லாம் செஞ்சது மாதிரி எல்லாம் என்ன லேப் சார் எல்லாம் லேப்ல படிய போடுங்க. லேப்ல
சரி, நான் நார்மலாக ஒரு கதை சொல்லுவேன். பல்ல வந்துட்டு எல்லா இடத்துலையும் மூவ் பண்ணி கொண்டு வந்து வைக்கிறவங்க ஒரு பல்லு பல மெமரி இருக்கும். அது போகிறதுக்கு ட்ரை பண்ணணும், அதை அடிச்சுட்டு இருக்கணும். அதுக்கு அந்த ரீட்டைலர் வந்துட்டு நீங்கள் ரொம்ப நாள் பண்ணுற மாதிரி இருக்கும். அது யூஸ் பண்ண போறீங்கன்னா இப்போ இதை பிளான் பண்ணி அதை நீங்கள் ஒழுங்காக பண்ண போகிறதா இது வேஸ்ட்டாக போயிடும். அதனால இதோட காஸ்ட் நான் சொல்கிறேன் உங்களுக்கு. அது அன்னைக்கு டேட் என்ன தாச்சோ நான் அன்னைக்கு சொல்கிறேன்னு சொல்லுவேன். தட்ஸ் ஒரு பெரிய ஸ்டோரி.
part of the orthodontic treatment. It is not optional. It is a mandatory. Why it is mandatory? Let us discuss. Retention is, as I said, is not a separate entity. It is an integral part of the orthodontic treatment. And retention plan should be in the treatment objective itself. Okay, it is not kept as a separate entity. We know that all the gingival and periodontal fibers always needs time to reorganize. Immediately there is no reorganization. Whenever you move the thing from one position to the another, the bone can remineralize and it can change easily, but not the soft tissues. This is a very important thing. Why? Because whenever you correct the protrudation, bimacular protrusion here, if you do correction, immediately you can see some sagging of tissues sometimes. Okay, you can see the lip which was very thick, giving some abnormal age look for the patient. Okay, so eventually what will happen, the activity of the lip decreases slowly day by day, and slowly the size and the shape of the lips also changes after 1 or 2 years. So always you tell the patient that immediately you can't expect this. The bone can change immediately with the orthodontic pressure, but not the soft tissue. This will change only if the activity decreases. Whenever there is a procrastination, there is more activity of the orofacial muscles. Whenever this activity decreases the tone of the muscles and ultimately decreases the size. Again, form and function are interdependent. Okay, whenever the function is reduced, the form also modifies according to the action. Okay, so coming to the retention, the gingival fibers have plenty of elastic fibers as such. And compared to periodontal fibers, gingival fibers are more stubborn when compared to periodontal. So always whenever you do some rotation corrections, you do a supraggressive fibrotomy. You relieve all the gingival fibers around the tooth so that reorganization of the fibers occurs and the reformant change is here. Otherwise, what will happen? The rotated gingival fibers again tend to re-rotate back, and again you rotate the teeth to the new position, the old position again. And always you should give some time for reorganization when the appliances are removed. We should know that we should realize that there is a soft tissue pressure constantly produced whenever there is a relapse tendency. You should understand that whenever there is a relapse, there is no equilibrium between tongue and the lips, or cheek and the tongue. Okay, there is some disparity in equilibrium. Force distribution is not going to be even. Even after sometimes, even after you finish a case perfectly, sometimes after 2 or 3 years, the patient will return with a small space in the upper anterior region. If you closely watch them, you can see that the tongue activity will be more. Maybe the tongue activity will be more and more. So this will be influencing the anterior teeth again, and there will be mild movement projecting out for the patient. You have to watch the tongue again. You have to. I can give a intraoral applying tongue spec or something, and you have to make the patient realize that the tongue is moving forward or the posture is abnormal. So first you have to realize that the tongue is going to play a major role in long-standing results. And of course, there is a changes produced by growth. It has been evidently proved that the long-term changes do occur. A small increment of growth do occur in later ages also, even in adult patients also. That small growth occurs. Some growth-related rotations also do occur. Rotations change in direction of, like particularly the mandible goes for a rotation, mild anti-rotation happens. So late growing also happens due to these reasons. Okay, so always expect here relapse, and you have to inform the patient there is a relapse. Whenever you do adult patient, there's always a tendency for relapse, and 30% of relapse is expected in almost 80 days. Okay, this happens because of the gingival periodontal fibers as well as for the between the muscle equilibrium, mismanagement between this muscle equilibrium. So you have to establish the muscle engrams as early as possible. That is why whenever you do a treatment, orthodontic treatment in young children is going to be very stable, and we will be happy with doing young children because so much of changes do occur, and even the functional changes, whatever you bring to this thing will enhance the patient's growth also. Okay, whenever you control the orofacial muscles, the zygomatic region will appear better, and so much of changes do occur. Of course, the genetic factor is there, but epigenetic factors, the environmental influences, whatever we are going to give, play a very major role. So this is just a chart where the loss of elasticity recoil of gingival fibers. This is from a standard textbook. A cheek, lip, tongue pressure, differential jaw growth, intraoral irregularity leads to changes in occlusal relationship. But the thumb rule is, even if the teeth are in a very stable position, you need a good retention for the purpose of gingival and periodontal fibers modification. The teeth are unstable. You are handling a adult patient. You are doing an expansion more than what you want. Okay, then always you're ready to accept that relapse and you should give a proper attention to the patients. So there are so much of retainers are there, and the sir will be telling about how this retainers, simple retainers, removable, etc.
Retention is mandatory for all cases.
It's not optional.
Not optional. This சில கேசஸ்ல சூப்பர் கொஞ்சம் பயப்பாடு சேர்க்கிறோம். And there is rotation. அதெல்லாம் பண்ணிருக்கும் போது அது பண்ணணும். Fixed retainers தேவைப்பட்ட கேசஸ்ல fixed retainers.
All crowding cases, lower anterior crowding cases have a tendency to relapse definitely.
கரெக்ட் பண்ண crowding cases கண்டிப்பா நம்ம fixed retainers.
Here the one important clue is the root position is going to play a very important role in correction of crowding. In CBCT we can assess the root position of all that they give. The root positions are good, it's not parallel, it's not equal or something. So you are in the safe zone then. Okay, so whenever you don't place the two parallel to each other everywhere, okay, you can expect some relapse there. Okay, you have to be very cautious with this and you can expect a relapse there and you have to go straight away with the fixed retainer.
இதோட எக்ஸ்டென்ஷன் ஆச்சு இந்த கொஸ்டினோட எக்ஸ்டென்ஷன் ஆகும் எவ்வளவு நாள் இந்த அப்ளை பண்ணணும் எவ்வளவு நாள் ஃபிக்ஸ்ட் ரேட் வச்சிருக்கோம்
Fixed retainer for lifetime. So whenever you have a fixed retainer, it is for lifetime. Why? Because whenever you take up the fixed retainer, there is a chance of because of the muscle equilibrium problem. Okay. So most of the cases, gingival orthodontic reorganization takes from 3 to 6 months as such. It varies from individual to individual. To be on safer side, always ask them to bear at least 1 to 1.5 years. Completely day and night, and after that for 6 months or 1 year they can wear only at night time.
ஆர்த்தோ அப்ளைன்ஸ் பாசிவா வச்சுக்கலாமா
இல்ல
ஆர்த்தோ லைன் லாஸ்ட் லைன் ரொம்ப நாளா போட்டு சொல்றாங்க
very good question. This cannot be done. Why? Because there should be some settling of the teeth primarily and upper teeth and lower teeth has to come down and settle for a perfect alignment, perfect function actually. They have to settle down. So you have to relieve all the teeth from the regular appliance and you have to go for a retainer. Okay, no other options. You can't leave that active appliance there.
எவ்வளவு வரலை கொடுத்தீங்க அப்ளைன்ஸ் பண்ணா எவ்வளவு வரலை நான் கேக்குறேன்
As early as possible, even on the day itself it's better. Otherwise at least next day or second day. The maximum relapse, the recoil takes within 2 or 3 days itself. You can even see mild space opening up in the case where whenever you just slip a week or 10 days.
சோ அதுக்கு நம்ம மேக்ஸ் ஒரு நாள் இல்ல அன்னைக்கே கொடுத்துறோம்
better, 1 or 2 days.
இப்போ வந்து அட்வான்ஸ்மென்ட்ஸ் பத்தி சொல்லுங்க சார் அதை யூஸ் பண்ணி எப்படி நான் வந்து பேஷண்ட்க்கு பெட்டரா ஆஃப் கொடுக்க முடியும் ரொம்ப லேட்டா போயிடுச்சு
அதுதான்
கொஞ்சம் வெயிட் பண்ணி
ஃபாஸ்டா முடிச்சிருவோம். So digital dentistry, we know that there is a use of CBCT to diagnose to find the root resorption, and you can see the canine infection case is very handy. You can see the where the canine portion root is there, and physical records. So you can scan the models, and the laser therapy is going to have a tremendous impact. You can have an axillary orthodontics through laser therapy, and TAGs. I have to insist upon TAGs.
TN05BY0459 orange car.
0459
நம்மள்ட்ட ரிசர்வ் பார்க்கிங் இருக்கு வண்டி எடுத்து போய் இங்கே எடுத்துட்டு அந்த மாதிரி ஏதாவது பார்க்கிங் வேற யாரும் இல்லை யாருமே எல்லாமே வேற ஏதாவது கார் ரிசர்வ் கார் பார்க்கிங்ல அலாட்டட் கார் பார்க்கிங்ல யாராவது விட்டுருந்தீங்கன்னா சொல்லிடுங்க எடுத்துட்டு வாங்க நீங்க இங்க விட்டுங்க சேஃபா
You can have the axillary orthodontics. Sometimes we have some patients with very slow movement of closing of extraction space. For them, you can have micro muscular perforation technique and low level laser therapy can be done. And when I discussed with Raghu also telling some basically takes a lot of time for cases. For them, they can these methods can be applied for them. And simulation software will be very easy for you people to convince the patient for orthodontics. You can simulate all the changes in what we are going to bring up with the surgery. And all these are all the latest advancements you can take up and explain. It will help in your practice.
இதுக்கு சப்ளை ஒர்க் அவுட் ஆகிட்டு வந்து அந்த வீடியோ சொல்லுவாங்க நான்கிட்ட வந்து முன்னாடி வச்சு பேஷண்ட் காமிச்சாலே போதும் ஆக்சுவலா பேஷண்ட் இமீடியட் எந்த கேசஸ்ல நான்கிட்ட ரெக்கார்ட் பண்ணி இருக்கோ அதை பார்த்து நம்ம மூவ் பண்ணி இந்த மாதிரி ஆயிடும் அப்படின்னு சொன்னாலே they are ready to take up that easily helped in many of the cases complications பத்தி ஆட் பண்ணி முடிப்போம் சார்
Generally, there is no big risk or complication of orthodontic treatment. But what they generally say is the root resorption is common for long-standing cases. Whenever you give long-standing treatment, always you have to wind up your treatment in 18 months maximum. But in Western countries, they are not advising 18 months, they are 36 months they are advising. But we don't do that much here in our country. But still, root resorption is going to be a challenge for what you call as abnormal forces when you give. So always check for root resorption. Time to time, taking a OPG is going to help you in whether to check for root resorption. And any tooth movement, if it is done abnormally, can be reversed back. So there is no hard and fast rule.
பெரிய பயன்தான் சார். ஆப்சோ பண்ணா பல்ல வேற எங்கயா போயிடுச்சுனா என்ன பண்ணுவீங்க?
எங்க போனாலும் திரும்ப we can bring it back if you. But the time is the problem. So if you have good time, then we can have no challenge.
இப்போ நானே பண்ணாலும் சரி, ஆப்லாம் டிஸ்பிளே கொலாபரேட் பண்ணி ட்ரீட்மெண்ட் பண்ணாலும் சரி. இப்போ நீங்க சொன்னபடி வந்து எல்லா கேசஸுமே நானே பண்ண முடியும்னு நினைக்கிறேன். ஆனா ஒருவேளை நான் கேட்டகரைஸ் பண்ணணும்னு நினைக்கிறேன். மைல்ட், மாடரேட், சிவியர், எது சிவியர் கேசஸ் எதை நான் எடுக்க முடியும்? ஒரு ஜெனரல் டென்டிஸ்டா ஆப்கோ எனக்கு தெரிஞ்சாலும் I'm not an experienced orthodontist, which are the cases that I should not take up?
Generally, malocclusion can be seriously divided into a dental and skeletal malocclusion. Whenever you say skeletal, it is going to be disparity between the jaw positions, jaw sizes, it may vary. Okay, so whenever you have a simple problem, mild, moderate, all comes within a small level where you can correct by yourself by simple. Within between 2 to 5 mm we can do all the discrepancy. If there is a discrepancy, the 2 to 5 mm is correctable. This comes in the mild case. This is a single tooth malposition. It is going to be a very mild case because of space discrepancy. You can have IPR, interproximal reduction, and you can bring the tooth. Even if there is single city cantilever, you can bring out easily. This is a mild case. Moderate case, 3 or 4 mm discrepancy, you have to do IPR in 3 or 4 teeth, and you can finish the case easily. This is a mild to moderate case. All skeletal cases, which cases with severe crowding, where there is a lot of space discrepancy more than 5 mm, is going to go for extraction, is going to be a severe case. And all syndromic cases, cleft cases, all going to be a severe case.
I will take home points to play which ones.
The take home points now is careful diagnosis. You have to, if you miss diagnosis, you are going to do something there. So generally, there is no risk involved in non-contact treatment if you do careful diagnosis. You have to do meticulous planning. Even before you start the treatment to the patient, you have to plan already. Even the retention plan also should be there in your meticulous planning, whatever you do. And there is a suitable selection of appliance. Okay, you cannot choose an appliance which cannot suit the patient. If you don't choose the appliance for the patient, you have to choose the appliance according to the problem of the patient. You don't choose an appliance and make the patient to have the appliance for that. Okay, then optimum orthodontic course. This is where the key lies. Okay, whenever you give optimum orthodontic course, you can achieve very good results. Whenever this course exceeds certain limits, it is going to have a tremendous impact on the supporting structures of the teeth, where you can have a bone loss or you can even a loss of attachment. Everything will happen, and there is a complication arises at this point of tension. And continuous monitoring is necessary, even though it is in alignment, it is in displacement, removal, means continuous monitoring has to be done. And always plan for retention even before we start it. This is one picture for your thought. This I got from William Prophet, the godfather of orthodontics. Can you read it?
Because lip increases and the facial soft tissues move downward related to the teeth with increasing age, what looks like excessive exposure of the teeth and gingiva on a smile at age 12 appears to be less excessive at age 14 and has totally disappeared at age 24. The patient has received no treatment between ages 12 and 24.
All cases don't go this way. And always there are exceptions.
சும்மா இருக்காலே நல்லா இருக்கும். நீங்க லேட்டா வந்துட்டு இவ்வளவு நேரம் பேசுறத டம்மி ஆக்கிட்டீங்க.
And always there are exceptions, and every case don't go this way. Be cautious. That's why I am giving a disclaimer. Every case don't go this way. In all cases, and there are some exceptions. And nature always has many surprises. And one more surprise I want to share with you. நேத்து முன்னாடி ஒரு பேஷண்ட் உள்ள வந்தாரு. டாக்டர் நீங்க தானே அந்த ஜான் ஆர்த்தர் கிளினிக் பக்கத்துல இருந்தீங்க. எனக்கு சின்ன பையன் இது கேட்கலாம். I want to be very specific. இல்ல டைல் சூப்பர் மார்க்கெட் எதுக்குதுல நடுவில் ஏதாவது குறுக்கில் ஏதாவது கௌஷிக் இருந்தால் எனக்கு வேற